This is the lecture over neurocognitive disorders. This is one of my favorite topics. This is what my area of specialty is in terms of psychiatry, but I'll try to keep this presentation short. Remember that when we talk about cognition, it is the operation of the mind that includes the mental faculties of knowing, perceiving, recognizing, conceiving, judging, reasoning, and imagining. So disorders then are those disorders that impair the brain's ability to carry out normal cognitive function. Remember that cognitive function has a direct relationship to daily living. Oftentimes, cognitive dysfunction, the term cognitive dysfunction or neurocognitive disorders is used interchangeably with the term cognitive disorders. So there are three main neurocognitive disorders, including delirium, dementia, and depression, which are considered the three Ds. These are discussed in more detail on page 339 in table 18-1. The major differences are explained there in that table as far as the onset, the cause or contributing factors, cognition, level of consciousness, activity level, emotional state, the effect on speech and language, and prognosis. Sometimes it's very hard to differentiate between delirium and dementia. As far as delirium is a confusion that develops quickly and fluctuates in its intensity. There is a change from the person's normal attention and awareness. They have a reduced awareness and responsiveness to their environment. They are disoriented and incoherent with a severe memory disturbance. Psychosis is not uncommon, and delirium is always secondary to some other condition. As far as prevalence, delirium is present in 60% of nursing home residents who are aged 65 years of age or older, and present in approximately 75 to 85% of patients with a terminal illness nearing death. And again, as far as comorbidity, delirium is always secondary to some other medical condition or substance use. Delirium occurs more commonly in older adults. Some causes are surgery, drugs, urinary tract infections, pneumonia, cerebrovascular disease, congestive heart failure, and some other acute illnesses. Essential features of delirium, again, is disturbed consciousness coupled with cognitive difficulties. So they have impaired thinking, memory, attention, and perception. You'll also see sundown syndrome in patients with delirium. There are four cardinal features of delirium. That is the acute onset and fluctuating course, their inability to hold their attention to something, disorganized thinking, and then a disturbance in their consciousness. They also have some other comorbid condition that we talked about on the previous slide that can contribute to the delirium. They also have cognitive and perceptual disturbances, including hallucinations and illusions. Sometimes they'll also have delusions, especially paranoid delusions. You need to assess their physical needs. They may not be able to meet their basic needs, including food, hygiene, water, and toileting. And then you may see some mood and physical behaviors, including agitation and aggression, as well as depression and anxiety. Common symptoms of delirium include autonomic hyperactivity. So all of those autonomic effects that you learned about in pharmacology and earlier in this class, you'll see will be hyperactive. You'll see an increase in their vital signs, increased respiration, increased heart rate. They also have hypervigilance, which, as I mentioned, sometimes they'll have paranoid delusions. So they'll be hypervigilant. They're constantly alert, scanning the room, trying to sort out their environment and figure out what's going on. You'll see mood lability, which they can change on a dime. They may strike out from fear or anger. They may cry or call for help. They may curse, moan, tear off their clothing, and then in a minute become laughing uncontrollably or become very apathetic. And again, agitation or anger is seen in delirium. The patient may become violent and require chemical or physical restraints. Other symptoms, their perception of the environment is abruptly disrupted. So even though they may be coherent and understand the current situation and environment, all of a sudden they're acutely confused. They also experience a disturbance in their consciousness. Suddenly they're no longer aware of time, place, or person. And then again, there is fluctuations in their consciousness. So they may be alert and oriented to person, place, and time during the daytime hours, and then at nighttime they become more acutely confused. And again, cognitive and perceptual disturbances may include illusions or hallucinations. Usually delirium hallucinations are visual and tactile, but they may also experience delusions, particularly because they're confused and not oriented. So then they try to process that reality and to kind of fill in the gaps of the parts that they don't understand, and it causes a fear response. So as far as planning and implementation, what are we going to do for these people? The most important thing is to manage the underlying cause. So for example, if the patient has pneumonia, we need to treat their pneumonia in order for them to get better. Nursing care is focused on patient safety. Communicating with these people requires simple and concrete phrases. You can attempt to reorient them to reality, but oftentimes that doesn't help. They need frequent reminders about where they are. Use the reality orientation aids like clocks, calendars, the dry erase boards in the rooms, name tags, things like that. And it's very helpful with these people to use the same staff. Sometimes that's hard in an acute care hospital, but that consistency will help them to remember where they are and why they're there. And then encourage support from the family members. Sometimes delirium can be very confusing and frightening for the family members as well, because it is so sudden, and sometimes it can be very severe. So family members need support, and then we need to encourage them that oftentimes usually delirium is reversible once the medical condition has been reversed. So that reassurance will help them to cope with the situation themselves. So some ways to communicate with the person who is experiencing delirium. Keep distractions to a minimum. So again, we've talked about this before. The milieu or the unit, if you're in the hospital, should be kind of sedate. When you're interacting with the patient, keep distractions to a minimum. So shut off the TV, ask the visitors to leave the room, pull the curtain, close the door. Always identify yourself, and that may require for you to identify yourself and re-identify yourself. Speak slowly with short, simple words. Focus on one piece of information at a time. Talk to the patient about familiar things in life. So, for example, you've introduced yourself and explained to the patient why you're in the room, and then maybe it is helpful to ask, has your daughter been in to see you today? Is she at work today? Or have your grandchildren been in to see you? Or something along those lines. Ask them about their pets, things that are familiar to them. That brings about a sense of grounding, and then that also connects you to what's normal in their life. Reinforce reality when the patient is delusional. So, for example, if they're paranoid, it brings to mind a particular patient that I had who was experiencing delirium, and he was very paranoid when the curtain was pulled, or if someone just, for example, when I was in the room, the nurse stepped in the room. When she saw that I was there, she stepped back out. And I just reinforced him that that was your nurse. She was just checking on you. She saw that I was here, and she'll be back later. When a patient is having delirium, always make sure that their eyeglasses or hearing aids are in place. They're having a hard enough time interpreting their environment. If their vision or hearing is impaired, then that will add to their confusion. And again, it's helpful to use reality orientation tools. So here's a question. Read this and think about it, and then pause it. And when you're ready, you can unpause it. So the correct answer is D. Our goal is for the patient to return to pre-morbid level of functioning. So in other words, that means that once the medical condition has been cured, then we would expect the delirium to be reversed. Okay, so shifting gears then, we're going to talk about dementia, which is a major neurocognitive disorder. Dementia is marked by impaired cognitive function and by slowly deteriorating social and occupational functioning, although the levels of alertness are generally not disturbed. So the patient will be alert but not oriented. Cognitive function progressively deteriorates, and there's global impairment of intellect with no change in consciousness. Memory, thinking, and comprehension are difficult, and the majority of dementias are irreversible. So there are different types of dementia. Alzheimer's is the primary diagnosis for major neurocognitive disorder. In this section in your book talks mostly about Alzheimer's disease then, but there are other types of dementia, and we talk about that on the next slide. So, primary dementias are irreversible and progressive and not secondary to any other disease. So, for example, Alzheimer's disease is a primary dementia. Secondary dementia is the result of some other pathologic process. So, for example, you can have AIDS-related dementia. There's also vascular dementia related to cerebrovascular disease. And there's Parkinson's dementia, and then also substance abuse dementia would all be considered secondary dementias. So biologic theories related to Alzheimer's disease. Age is the most important risk factor. In terms of genetic studies, early onset Alzheimer's disease is rare and is probably inherited, whereas late Alzheimer's does not seem to have an obvious inheritance pattern. They have identified a form of a gene on chromosome 19 is responsible for making a protein called apolipoprotein E, which is identified as a risk factor. So if the patient carries that protein, then they are at an increased risk of developing Alzheimer's disease, late onset. The etiology or the actual pathology of Alzheimer's disease is that it is a very complex disease and that there is damage to the brain before symptoms start. Specifically in Alzheimer's disease, the patient will develop cerebral atrophy, which incidentally also happens in patients who do not have Alzheimer's disease, secondary to aging. But Alzheimer's disease patients also develop what's called neurofibrillary tangles. Those neurofibrillary tangles are damaged remains of microtubules that allow nutrients to flow through the neurons. Those tangles form in the hippocampus, which is responsible for recent memories. Alzheimer's patients also have neuritic plaques, which are plaques that develop on the neurons, particularly a buildup of beta amyloid protein that results in those plaques. In terms of genetics, we already mentioned that early onset Alzheimer's disease is relatively rare, but it does have a familial link, and then we talked about the chromosome abnormalities. So cognitive impairment in dementia, in this case Alzheimer's disease, involves the 4 A's. Amnesia, which is memory impairment. Aphasia, which is the loss of language ability. Apraxia, which is the loss of purposeful movement in the absence of sensory or motor impairment. And agnosia, which is the loss of sensory ability to recognize objects. These patients also develop loss of executive function, which means that they have an impaired ability to plan and organize, and their abstract thought is impaired. When patients begin to develop cognitive impairment, they begin to use defense mechanisms. In Alzheimer's patients, it's pretty common to see them use confabulation, which is the medical term for when patients make up stories or make up answers in order to maintain their self-esteem. It's important that we not ask patients, do you remember? Or can you tell me? So, for example, it's hard for a patient, particularly early in the stages of Alzheimer's disease, to ask them, do you remember what day it is? Or do you remember my name? Because it's their defense mechanism of confabulation to fill in that information or to make that up. So oftentimes it's a more reliable assessment to ask them instead, let me see, what are your plans for this weekend? And then as they begin to tell you that, then you can ask them how many more days until the weekend. Or you can just ask them more bluntly, what is today's date? But if you preface it with, can you remember or can you tell me? Oftentimes you'll see confabulation surface. Perseveration then is a repetition of phrases or behaviors. You'll see this repetitive phrase later in dementia or when the patient is experiencing some type of stress. So according to the DSM-5, Alzheimer's disease accounts for 60 to 90% of all dementias. It is the 7th leading cause of death in adults and the 5th leading cause of death in those over age 65. The average lifetime prevalence of Alzheimer's disease is about 12.5% in patients over 65, and it jumps to 14% in patients over 71. Alzheimer's disease has 4 stages. Stage 1, which is also mild Alzheimer's disease, includes forgetfulness. Stage 2 is moderate, where the patient has marked confusion. It's notable that they have some form of cognitive impairment. Stage 3 is moderate to severe, when the patient is unable to identify familiar objects or people. And then stage 4 is late or end-stage Alzheimer's disease. Those stages are on page 347 in table 18-2. So that's important for you to be able to differentiate between those stages. Nursing diagnoses for Alzheimer's disease. Can include risk for injury, impaired verbal communication, impaired environmental interpretation syndrome, impaired memory, confusion, caregiver role strain, and then of course self-care deficit, knowledge deficit, and then there are others as well. Planning. It's important when you're caring for a patient who has Alzheimer's disease or any type of dementia to make sure that their basic needs are met first. So when you're thinking of Maslow's hierarchy, those things that are at the bottom of the pyramid, such as toileting, food, and water, need to be your focus first. And then we will identify their level of functioning. Delirium delirium superimposed on dementia. And those patients are particularly challenging. And we hope that once the delirium cause has been treated, they'll return to their previous level of functioning. But unfortunately, that stressor can cause their Alzheimer's or their cognitive impairment to worsen permanently. Remember, too, when you're taking care of these patients who have Alzheimer's disease or dementia, to assess the caregiver's needs. There is a high rate of burnout in family members who are caring for patients with Alzheimer's disease. So social services would definitely be an appropriate referral for those family members so that we can give them some relief. And then, so that leads into the next one, which is plan and identify appropriate community resources. Remember, when you're communicating with patients with Alzheimer's, they often have difficulty finding the right words. They use familiar words repeatedly. They invent new words to describe things, neologisms, which we mentioned when we were talking about schizophrenia. They lose their train of thought, and they rely on nonverbal gestures to communicate. So some guidelines when caring for a patient with Alzheimer's disease: always identify yourself. Call the person by his or her name at each meeting. Hello, Mr. Jones. My name is Janine. I'm going to be your nurse today, whatever the case may be. And you may need to do that every time you enter the patient's room. Speak slowly. Use short, simple words and phrases. A lot of times you identify yourself. I'm here to take care of you today. And then take a break. Give them a minute to process that, and maybe 10 seconds or so before you move on to your tasks. Maintain face-to-face eye contact and be near the patient when you're talking, only 1 or 2 arms lengths away. It's important that you try to make eye contact with them. Of course, they're confused, and if they're afraid, it might be difficult. Patients with dementia require a lot of patience. Focus on one piece of information at a time, and again, talk with them about their familiar things. Some therapeutic communication is to encourage them to reminisce about happy times. So, for example, you may encourage them to talk about their children or their family or, whatever their hobbies were when they were healthy. When the patient is delusional, acknowledge their feelings but reinforce reality. So you may tell them that must be distressing, or that must feel scary, or something like that. But then remind them that they're safe now. That must be scary, but you're safe now. Don't argue or refute their delusions. Don't try to convince them that they're wrong or their delusions are not real. Rather, just try to encourage them that they are safe. Again, have them wear their glasses or hearing aids. Keep the room well lit. Keep clocks, calendars, and personal items in clear view to help ground them. Reinforce the patient's pictures, nonverbal gestures, X's on calendars, and other methods to present reality to them. If the patient gets into an argument with another person, separate them. Sometimes they just need a timeout. And by timeout, I don't mean seclusion. Sometimes they just need to be distracted or taken away from the person who has upset them, whoever that is, whether it's a family member, it could be you, could be the physician. Sometimes they just need to be removed from the situation. And then after about 5 minutes, just explain to them, you were getting upset with Joe, so I thought that maybe you guys needed to be separated for a few minutes. Or I could tell that your son was upsetting you, so I asked him to leave for 5 minutes. If the patient is verbally aggressive, then acknowledge the patient's feelings and then try to shift the topic to something familiar. I know this is upsetting for you because you always cared for others. Or I know this is upsetting for you because your son has taken care of you for so long. Just try to, again, reminisce on those positive aspects of their life. So here's another question for you. In caring for a patient with late Alzheimer's disease, which nursing diagnosis demands the nurse's highest priority? You can use the table 18-4 on page 347 to help you answer this question. You can review there the hallmark symptoms of stage 4 or late Alzheimer's disease. And pause it if you need to. The correct answer is A. The patient is bedbound, so risk of falls is not so great. A risk for decubitus exists, but this is addressed as a need related to self-care deficit. So in terms of prioritizing, the greatest priority here is a patient's risk for injury. Their self-care deficit is followed closely to that. Their chronic low self-esteem obviously is not a priority. Impaired verbal communication is also secondary to both self-care deficit and risk for injury, but the highest priority out of this list is risk for injury. Okay, so let's talk about how we're going to medicate these people. Remember that Alzheimer's disease does not have a cure, so the focus of treatment is to maintain their independent functioning for as long as possible. We want to we want to slow disease progression. So these drugs that we're going to talk about are aimed at slowing disease progression. Pharmacologic therapies are discussed on starting on page 356. As with all drugs in older adults, it's important that we start low and go slow. In other words, start at the very lowest dose, sometimes lower than the recommended therapeutic dosing, and then titrate that up to effectiveness slowly. There again, there's no cure for Alzheimer's disease. These drugs are intended to delay and prevent symptoms from becoming worse for a limited time. They're useful for mild to moderate Alzheimer's disease. Once the patient has progressed to severe Alzheimer's disease, they really don't do much for the patient. What they do, their mechanism of action is they prevent breakdown of acetylcholine and stimulate the nicotinic receptors to release more acetylcholine. These are the list of drugs that are used to treat Alzheimer's disease. There's also, interestingly, potential therapeutic use of insulin in Alzheimer's disease. Remember that adjuncts may be used, including if they have coexisting mood disorders like depression, which in this case the physician or the prescriber will be concerned about side effects. Selective serotonin reuptake inhibitors have the lowest side effect profile than like tricyclics or MAOIs, so they're better tolerated, particularly Wellbutrin and Effexor. And a lot of times you'll see Remeron used as an adjunct at bedtime, which will also help with that sundowning syndrome, help the patient to sleep. A lot of times, too, in terms of sundowning, if you keep the patient up and active during the day, they will sleep better at night. That seems like that's common sense, but that's something that I know nurses in acute care hospitals struggle with. And even families, they'll think, well, he didn't sleep all night last night, so he's getting caught up on his sleep today. But what that really means then is that they're just going to be up all night again. So sometimes you'll see atypical antipsychotics that are being used extensively for treating behavioral symptoms of Alzheimer's disease, particularly those patients who have behavioral disorders, such as agitation and aggression. Just remember that those do carry a black box warning from the FDA that says that patients with dementia who use antipsychotics are at an increased risk for mortality. Now you will see older patients with dementia who have those behaviors who are treated with antipsychotics despite that black box warning, and the purpose there is that sometimes the benefits outweigh the risks. So even though the patient has that increased risk of mortality, they have a better quality of life. So even though their mortality is even though they're at risk for death secondary to the use of those drugs, the time that they have left is more enjoyable for the patient and themselves. So it's a matter of whether or not their quality of life is being impaired by those disruptive behaviors. So that's why sometimes you'll see them. So that's the end of that chapter. If you have any questions, be sure and let me know. You got my contact information, and then I will see you in class again as well.